Right now, with every single step you take, a force equal to roughly 1.5 times your body weight is traveling up through your feet, into your ankles, your knees, your hips, and your spine. Every single step. If you walk an average amount, that is somewhere in the region of 4,000 to 5,000 impact events hitting your body today alone. And most people never think about their feet at all until something hurts. But here's the thing that genuinely surprises people when I explain it. The damage that starts in your feet rarely stays in your feet. There is a chain of consequences, mechanical, neurological, circulatory, and metabolic, that runs from the soles of your feet all the way to your brain, your heart, and your immune system. And almost none of it announces itself clearly until it has been quietly building for years. Hi, I'm Dr. James Whitfield. I'm an emergency medicine physician, and I have been working in the ER for just over a decade. In that time, I have personally treated more than 40,000 patients. And I can tell you that the patients I see coming in with back pain that turned out to be decades of poor foot mechanics, with infections that started from a blister that was never taken seriously, with cardiovascular decline partly driven by years of reduced mobility from foot pain, those patients almost always had no idea the connection existed. My whole mission with this channel is to stop people from ever needing to come through those ER doors. And that starts with understanding the systems inside your body that are quietly talking to each other in ways you have never been told about. So here is exactly what we are going to cover today. I am going to walk you through the numbered mechanisms by which your feet, specifically what happens in your feet, damages systems elsewhere in your body. Each one has a real physiological mechanism behind it, real studies behind it, and a real practical takeaway you can act on. And at the end of this video, I am going to give you a simple framework you can start using this week to interrupt these chains before they progress further. Before we get into it, if you are not yet subscribed, please consider hitting that button now. Only about a quarter of the people watching these videos actually subscribe, and growing this channel is the only way I can keep making content like this. I promise that if you get to the end of this video and did not learn something genuinely new about your own body, you can unsubscribe with absolutely no hard feelings. Right, let's get into it. Number 1. Collapsed arches and the slow destruction of your knees, hips, and spine. Your foot has 3 arches. Most people know about the medial longitudinal arch, the one you can see on the inside of your foot when you stand. But there is also a lateral arch on the outside edge and a transverse arch running across the ball of your foot. Together, these 3 arches form a structure that is extraordinarily good at one specific job: absorbing and distributing the mechanical load of every step you take. When those arches function correctly, the impact of each footfall is spread across a wide surface area, absorbed progressively, and transferred upward through your ankle in a controlled, aligned direction. When the arches collapse, a condition called pes planus, or flat foot, or when they become excessively high, a condition called pes cavus, that load is no longer distributed the way it was designed to be. Instead, it concentrates, and it travels upward in a misaligned direction. Here is the chain. A collapsed medial arch causes your foot to roll inward with each step, a motion called overpronation. When your foot rolls inward, your shin rotates internally. When your shin rotates internally, your knee tracks inward rather than straight forward. When your knee tracks inward consistently, the cartilage on the inner compartment of your knee joint, the medial meniscus, and the articular cartilage beneath it absorbs disproportionate load every single day. Multiply that by thousands of steps and years of walking, and you have a direct mechanical explanation for why medial knee osteoarthritis is the most common form of knee arthritis in adults. There was a study published in the Journal of Orthopedic Research that tracked adults with measurable overpronation over a 7-year period and found they had significantly higher rates of medial compartment knee degeneration compared to adults with neutral foot mechanics, even after controlling for body weight and activity level. The foot mechanics alone were an independent predictor, and it does not stop at the knee. That inward rotation of the shin also tilts the pelvis, which the lumbar spine then compensates for by developing a lateral curve. Chronically compensated lumbar mechanics are one of the most common underlying causes of lower back pain that people spend years treating at the symptom level, chasing the back, when the origin is in the foot. The practical takeaway: if you have knee pain, hip pain, or chronic lower back pain that has never fully resolved, ask a podiatrist or sports medicine physician to assess your foot mechanics specifically. A proper gait analysis and appropriate orthotics, custom or well-chosen over-the-counter arch supports, can interrupt this chain at its source. It will not undo existing cartilage damage, but it will meaningfully slow its progression. Number 2. Peripheral neuropathy in the feet, and what it means for your brain and your fall risk. Your feet contain some of the most densely packed sensory nerve endings in your entire body. The job of those nerve endings is to send constant positional information upward through your peripheral nerves into your spinal cord and up to your brain. This system, called proprioception, is essentially your body's internal GPS. It tells your brain where your feet are in space, how the ground is angled, how much pressure is under each part of your sole, and how quickly to make micro-adjustments to your balance with every single step. When peripheral neuropathy develops in the feet, those nerve endings stop sending accurate signals. The most common cause of peripheral neuropathy in the United States is diabetes. Chronically elevated blood sugar damages the small blood vessels that supply the peripheral nerves, and the nerves begin to degrade. First comes tingling or numbness, then comes the loss of fine positional sensation. And here is where it gets really interesting. When the proprioceptive signal from your feet degrades, your brain does not simply accept the deficit and adapt gracefully. Instead, it compensates by leaning more heavily on your visual system and your vestibular system, which is your inner ear balance mechanism, to maintain posture and balance. This compensation works reasonably well in bright, familiar environments, but in low light, on uneven ground, during any situation where vision is reduced, the compensatory system is not enough, and the result is a dramatically elevated fall risk. There was a landmark study published in the New England Journal of Medicine examining adults over 65 with diabetic peripheral neuropathy, and it found their risk of a serious fall-related injury was over 2.5 times higher than age-matched adults without neuropathy. Serious fall injuries in adults over 65, we are talking hip fractures, traumatic brain injuries, are one of the leading causes of loss of independence and early mortality in that age group. And the foot is where this chain quietly begins. But here is what most people do not know. The same proprioceptive degradation occurs even in people without diabetes, simply from years of wearing overly cushioned, rigid footwear that does not challenge the sensory nerve endings in the foot at all. The nerves, like any neural pathway, respond to stimulation. Deprive them of varied sensory input for decades, and their sensitivity measurably declines. The practical takeaway: if you have diabetes, an annual foot examination, including monofilament testing, which is a simple test where a clinician touches specific points on your sole with a fine filament to assess sensation, is not optional. It is the earliest detectable warning of neuropathy, often years before symptoms appear. Ask your primary care doctor specifically for it. And for anyone, incorporating some time each day walking barefoot on varied natural surfaces, grass, sand, uneven ground, provides genuine proprioceptive stimulation that helps maintain nerve sensitivity over time. Number 3. Foot pain, reduced mobility, and the cardiovascular consequence nobody talks about. This one operates through a mechanism that sounds almost too simple until you look at the data, and then it becomes impossible to ignore. Cardiovascular health, specifically the health of your heart, your blood vessels, and your metabolic markers like blood sugar regulation, insulin sensitivity, and inflammatory burden, is profoundly dependent on habitual physical activity, not extreme exercise, just regular movement. Walking is one of the most studied and consistently beneficial forms of physical activity across every cardiovascular outcome we measure. Now here is the chain. Chronic foot pain from plantar fasciitis, bunions, Achilles tendinopathy, metatarsalgia, Morton's neuroma, or simply the accumulated mechanical damage from decades of poor footwear causes people to walk less, not because they are lazy, because it hurts. Every step becomes a negotiation. You take the elevator instead of the stairs. You sit down sooner. You skip the evening walk. You drive to places you used to walk to, and slowly, over months and years, your daily step count drops from maybe 7 or 8,000 steps to 3 or 4,000 or less. There was a study published in the European Journal of Preventative Cardiology that tracked over 72,000 adults over an extended follow-up period and found that each additional 1,000 steps per day was associated with a roughly 15% reduction in all-cause mortality, independent of other lifestyle factors. 15% per 1,000 steps. And there was a clear threshold effect around 7,500 steps per day, where the protective benefit was particularly strong. What we know is that the people who stop walking due to foot pain do not simply lose the cardiovascular benefit of those missing steps. They also lose muscle mass in their lower limbs faster than they would otherwise, which accelerates insulin resistance. They lose the blood pressure lowering effect of regular movement. Their resting inflammatory markers rise. And inflammation is the soil in which cardiovascular disease, type 2 diabetes, and several cancers grow. The practical takeaway. Foot pain is not something to manage by resting indefinitely. That is one of the most common mistakes I see. Rest removes the pain signal temporarily, but the underlying cause continues, and in the meantime, your cardiovascular system is paying the price of the inactivity. Seek a proper diagnosis for your foot pain. Whether it is plantar fasciitis, a stress fracture, tendinopathy, or something structural, most of these conditions have evidence-based treatments that allow you to maintain some level of activity during recovery. A podiatrist, an orthopedic specialist, or a physical therapist can build you a plan that manages the pain while protecting your cardiovascular health at the same time. Number 4, foot wounds and the infection pathway that can become limb and life-threatening. Let me be really honest here, because this mechanism is one I see turn catastrophic in the ER in a way that is genuinely preventable. Your feet are constantly in contact with the ground. They are the part of your body furthest from your heart. Blood supply to the feet, particularly to the small capillaries in the skin and the tissues of the toes, is the most marginal in the entire body. When anything compromises that blood supply, through diabetes damaging small blood vessels, through peripheral artery disease narrowing the larger vessels, through smoking constricting the microcirculation, even through prolonged compression from ill-fitting footwear, the ability of the foot tissue to resist infection and heal wounds drops sharply. A small cut, a blister from a new shoe, a cracked heel that breaks the skin barrier. In a person with good circulation and healthy immune function, these things heal in days. In a person with compromised foot circulation, those same small breaks in the skin become entry points for bacteria into tissue that lacks the blood supply to mount an effective immune response. The infection spreads not just across the skin surface, but downward, into the subcutaneous fat, into the tendons, into the bone. What becomes clear in the ER is that by the time patients come in with a serious foot infection, the process has usually been developing for days or weeks that felt manageable at home. Osteomyelitis, that is infection of the bone itself, is extraordinarily difficult to treat once established and often requires surgical debridement. Diabetic foot infections are the leading cause of non-traumatic lower limb amputation in the United States, accounting for more than 60% of all cases, according to data from the Centers for Disease Control. There was a study published in Diabetes Care following adults with type 2 diabetes over a 5-year period that found that patients who performed daily foot self-examinations and had annual clinical foot reviews had a 50% lower rate of serious foot infections requiring hospitalization compared to those who did not. 50%. From looking at your feet every day. The practical takeaway. If you have diabetes, peripheral artery disease, or you smoke, your feet need daily examination every single day. Look between the toes. Feel for areas of unusual warmth or firmness. Check the soles. Any wound or sore that has not begun to clearly improve within 48 hours in these patient groups is a same-day medical review. Do not wait for it to hurt more. With neuropathy, many of these wounds genuinely do not hurt, and the absence of pain is not reassurance. Number 5. Chronic foot tension, sleep disruption, and the systemic inflammation pathway. This one is less well known, and I want to explain it carefully because it connects foot health to something that affects your whole body in ways that feel completely unrelated. Plantar fasciitis, the most common cause of heel and arch pain, affects roughly 1 in 10 adults at some point in their life. When it is active, it tends to be worst first thing in the morning, those first agonizing steps out of bed, and it often flares in the evening after a full day of loading. Evening flares of pain are relevant for a specific reason. Pain activates your sympathetic nervous system, your fight or flight system. Sympathetic activation in the evening raises cortisol, raises heart rate, delays sleep onset, and fragments sleep architecture, reducing the proportion of deep, restorative, slow-wave sleep you get. Now, here is where it gets really interesting. Slow-wave sleep is the stage during which your brain runs its glymphatic clearance system. That is the mechanism by which your brain flushes out metabolic waste products, including proteins associated with neurodegeneration. It is also the stage during which your immune system is most actively calibrated, during which growth hormone is secreted, and during which your inflammatory cytokines, the chemical messengers of inflammation, are dialed back from the day's activity. Chronic sleep fragmentation from any cause, including chronic pain in the feet, produces measurable elevations in systemic inflammatory markers, specifically interleukin-6 and C-reactive protein. There was a study published in JAMA Internal Medicine that followed over 7,000 adults and found that adults reporting chronic pain-related sleep disruption had C-reactive protein levels nearly 40% higher on average than age-matched pain-free controls. C-reactive protein is one of the most reliable markers of chronic systemic inflammation we have. And chronic systemic inflammation is independently associated with accelerated cardiovascular disease, accelerated cognitive decline, impaired immune function, and increased all-cause mortality risk. So the chain runs like this. Unmanaged plantar fasciitis causes evening pain. Evening pain disrupts sleep. Disrupted sleep elevates systemic inflammation. Chronic systemic inflammation damages your cardiovascular system, your brain, and your immune function. From your heel to your heart and your brain, through the single intermediary of sleep quality. The practical takeaway: plantar fasciitis is not something to simply stretch and hope improves over time, though stretching the plantar fascia and the Achilles tendon is genuinely effective when done correctly. Evidence-based treatment includes specific calf and plantar fascia stretching protocols before the first step in the morning, supportive footwear with appropriate arch support throughout the day, avoiding prolonged barefoot walking on hard floors during an active flare, and in persistent cases, a short course of physical therapy that addresses the full kinetic chain from the calf through the Achilles insertion. Most cases resolve significantly within 3 to 6 months of consistent treatment. The critical thing is not to let it run for years undertreated, because that is when the sleep disruption and the inflammation consequences become genuinely systemic. Now here is the practical framework I promised. Think of it as a 5-point foot health audit you can do this week. First, assess your arches. Stand on a wet floor with bare feet and step onto a piece of paper or a dark surface. Look at the imprint. A full flat imprint with no visible arch cutout suggests overpronation. A very narrow imprint with almost no midfoot contact suggests high arches. Either warrants a conversation with a podiatrist about whether your current footwear and any orthotic support matches your mechanics. Second, test your foot sensation. Sit down, close your eyes, and have someone lightly touch different areas of your soles with a thin object. The blunt end of a pen is fine. You should be able to feel light touch consistently across the ball, the heel, and the toes. If there are areas of reduced or absent sensation, mention it to your primary care doctor at your next visit and ask specifically about monofilament testing. Third, track your daily steps for 1 week without changing anything. Just observe. If your average is consistently below 5,000, and particularly if foot pain is a contributing reason, that is the gap most worth closing from a cardiovascular risk standpoint. Fourth, examine your feet tonight. Take 2 minutes. Look at the skin, the nails, the spaces between the toes. Look for any cracks, sores, areas of redness, swelling, or discoloration you have been ignoring. If you find something that has been there more than a few days, it needs to be seen. Fifth, look at your footwear. The shoes you spend the most time in every single day are your foot mechanics for those hours. If your daily shoes have no arch support, significant heel wear on the inner or outer edge, or if they compress your toes into a narrow toe box, that is a correctable mechanical stressor that is accumulating quietly with every single step. The bigger picture I want to leave you with is this. Your feet are the foundation of your body in the most literal sense. But they are also connected upward through mechanical chains, neurological pathways, circulatory networks, and inflammatory systems to virtually every major organ and system in your body. And the connection almost never announces itself directly. Your knee does not tell you the problem started at your arch. Your cardiovascular system does not tell you that part of its decline came from the foot pain that made you stop walking 3 years ago. Your brain does not tell you that some of its inflammatory burden came from years of disrupted sleep driven by heel pain. This is what modern medicine is genuinely not good at. It treats the knee, the heart, the brain, each in its own department, each on its own terms. What it rarely does is trace the chain back to its origin. And that is exactly the work I am trying to help you do here before you ever need to come through those ER doors. If this video gave you something useful today, please share it with someone who has been dealing with foot pain and thinks it is just a minor inconvenience. It might just change how seriously they take it. And if you are not subscribed yet, please do hit that button. Thank you genuinely for watching. Take care of your feet. They are carrying more of your body's future than you probably ever imagined.